All of the food we eat and much of the clothing we wear comes from plants and animals that are raised on farms. Farms are different in type, in size, and even in name.
Welcome to Barn Talk. What happens at the barn stays in the barn until now. We're going to let it all out for you guys. Today's going to be a special episode. We got a guest on that we think can provide a lot of value to guys. But before we get into it, you guys know the drill. Pay the fee. If you get any value from the show, share it out with your friends, family, coworkers, employees, team members, whoever. The more you guys do that, the better guests we can get on, the better content we can make, the more content we can make. And it's just better for everybody. So thank you to all that have been doing that. Feel free to leave a review on Spotify or Apple. We're almost up to 1,000 5-star Spotify reviews. So please, let's get to that number by the end of this, by next week's episode. Let's try to get to 1,000 5-star Spotify reviews, and we're up to like 381 on Apple. So iTunes they got a little ways to go before they catch up to Spotify, but that's all right. We still really appreciate it. And if you guys want to buy some Barn Talk merch, feel free. We got it in the link in the description if you're watching on YouTube, or in the link in the show notes if you're listening on Spotify or Apple. So
yeah, not only that, the YouTube version of Barn Talk is on fire.
It is on fire.
I don't know, but I think I'll be willing to bet you that in the next 10 days, our Barn Talk subscriptions on YouTube are going to surpass our subscriptions on This'll Do Farm, which is crazy.
It is crazy because we've been doing This'll Do Farm for almost 4 years. And we're almost to 50,000, and we've been doing Barn Talk for what, 2 years? We're gonna almost hit 50,000. So it's crazy how that works.
I guess our pigs aren't as interesting as we thought they are, or else Barn Talk is just that damn.
You just
good.
get to run your mouth more on here. That's why.
I do. That's for sure. Mm-hmm. So I'd like to say that it's wisdom, but it's probably just age. I had to put my glasses on because I couldn't remember what I wrote. So one of the perks of living in small town America, especially in the Midwest, has always been that everybody that you get to work with, you get to know because they're part of your little town, and that included, your local hospital, your local doctor, and having a local doctor and a nearby hospital is something we've all kind of taken for granted, and all that is changing. And for a lot of people, it has changed, and for a lot of other people, it is changing, and I think it's going to continue to change, and that's not a good thing. As consolidation in the healthcare industry grow, people are finding themselves without a local doctor and having to travel a lot further to get a checkup or a procedure and dealing with people they don't know, which that's never fun when you've got a healthcare issue. And our guest today, he is right in the thick of it. He's the CEO of our local hospital here, Washington County Hospital and Clinics, and he's formerly the COO of University of Iowa Physicians, and he knows the struggle because he's living it every day, and we thought that was a really interesting subject that we wanted to dig into, and so he's working hard to keep rural health care accessible for citizens. But the other side of that is you got to keep the hospital profitable enough that you can keep the doors on.
Todd Patterson, welcome to Barn Talk.
Hi, Sawyer. Thanks for having me.
Yeah, thanks for coming down.
Yeah.
So to give us just a little bit of background of who you are and kind of what you're doing today, and kind of how you got here. That's pretty broad, but I think you can handle it.
Yeah. Well, okay. I'll just start from the beginning. I'm originally from Bettendorf, Iowa, but when I was growing up, I actually lived in multiple places in Iowa. I was born in Britt, Iowa, which is north central Iowa. Moved from there to Cedar Falls. My dad got his master's degree at UNI in education, and he got a job working in Ottumwa. So we lived there for several years until like 1982 when the Hormel plant down there closed, and everybody lost their job, including him. So he got transferred to Bettendorf, where I finished out my schooling. So went to the University of Iowa and I got an undergraduate degree in psychology and a master's degree in business. And while I was there, I started working at the University of Iowa Hospital in about 1997. Actually, I started there as an undergraduate student in 1994 and I would copy charts. I copy patient medical records and mail the, you know what a copy machine is?
Yeah.
I don't know if I've ever used one, but I know of one.
I used that and a typewriter and microfilm back in that day. So that's where I started, like sort of the quote unquote copy room, and kind of worked up from there and got a full-time job after I graduated in 97 and or 96, 97. And did some sort of nondescript kind of jobs for a little while. And then I started to get into healthcare administration in early 2000s. And so the way I got into administration is I screwed some stuff up. That's kind of an interesting story. I had some really good ideas that didn't work out particularly well, but the ideas were really good. And so I had some mentors that kind of took an interest in me from a kind of vision and idea standpoint, not necessarily execution standpoint at that time, which is still kind of an issue I have. So my first kind of real job in healthcare was I was an assistant administrator in the ear, nose, and throat department at the University of Iowa, which at the time, and maybe still is, was the second ranked ENT department in the country. And so I did that, became administrator after a year and a half or so of doing that. So I was no longer the assistant. And then I did that for about 8 years. I got a call from the dean of the College of Medicine, who I did not know at the time. And he said, I need a chief of staff, and you're going to be my chief of staff. And
Yes, sir.
I said no.
Oh.
Like I don't know what that means.
Yeah, what does that mean?
For one thing. But it was assistant dean for administration, or what we used to call the ass dean. I guess I should ask. Can you swear on this thing?
Yes, you can.
Within reason?
This
Yeah,
has
yeah.
has the right disclaimers.
All right. So you know, I thought it was kind of funny. So I went down and at least talked to him, and I said, I don't think I want to be the ass dean and the chief of staff. I don't know what this job is. And so I was playing basketball a couple days later, and a guy came into the gym and literally put me in a hammerlock, and he said, you're going to be the dean's chief of staff. Go see him today. End of story. And that guy was Peter Denson, who is an infectious disease doctor. And so I went in to meet the dean. His name was Paul Rothman, is still a friend of mine, and became his chief of staff, which meant I basically, whatever needed to be done, I did within the medical school, within the research enterprise at the University of Iowa, or within the hospital that required, I guess, dirty work, like the hatchet man.
Yeah.
I'd help him meet with donors. We'd go down to Miami, for instance, for the Orange Bowl in 2010, and we meet with all these donors, and he'd give me a big stack of paperwork and said, memorize all this stuff. And then we'd be sitting down with these very rich donors, and I'd be like, this is John Smith. He likes to bake, and he's got, a 48-inch deck on his lawnmower, and he really likes to talk, and then the dean would talk about that. So he actually left in 2012, and he became the president and CEO of Johns Hopkins Medicine.
Wow.
And I took a look. He recruited me out there. I took a look at doing that, but this is my wife's hometown. She's got a business here. She's based here. And I said, hey, should we look at Baltimore, to look at going to Hopkins? And she said, no. I said, well, we should discuss it, right? And she said, no. And so that was the end of that.
Yep.
So then I moved on with, you don't want to be the chief of staff for the next dean because it's kind of a personal relationship. Yeah. So I became the executive director of the Heart and Vascular Center at the University of Healthcare then, which was a really big job, about $160 million endeavor at that time, probably much bigger than that now. And it encompassed cardiothoracic surgery, so heart and lung surgery, heart transplant, plus cardiology, heart interventions, cath lab, and also vascular surgery. I did that for a little while, and I got a call from the University of Iowa Physicians Group, and kind of like what happened when I was in the other place. He said, "Hey, I want you to be the chief operating officer for the University of Iowa Physicians, which is the I don't know, there's 1,100, 1,200 physicians that serve all the locations in the University of Iowa Healthcare.
Yep.
So on main campus and all their outreach areas, et cetera. And he said, no, I don't want to do that. So they kept searching, and then he called me back and said, no, you're going to have to do it. So I did it on an interim basis, and then I took that job full time. So I did that for 4 years till 2018 when the CEO position here in Washington, Iowa opened up, and I decided that I'd had enough of commuting. I've been commuting from Washington to Iowa City for about 21 years.
Yeah.
And really, I felt like that I had developed skills at that time that I could bring back to the community and apply those here in a way that I could see them be more effective. So,
Right.
you know, when you work at a place like the University of Iowa, where there was, at the time I worked, there were 16,000 employees, you know, it's hard to make any
See the impact.
It's hard to see the impact. And so I wanted to, or, you know, if you have a good idea, you got to convince 800 people that it's a good idea. And the bureaucratic aspects of it and the administrative burden and inertia is really hard to kind of overcome. So I felt like if I was down here, it'd be a lot more autonomy, freedom to kind of decide what direction we want to take, and then feel like you have a direct impact on your family, your community, the people you know.
Right.
You know, and so that's what prompted me then to move in 2018. So I've been here now just 5 years in April, and have really enjoyed it. So that's also, I guess I should say I was an extremely talented athlete.
Yes.
There you go. Throw that in there.
Hammer throwing? What was it?
Hammer throwing. Yes. Ball peen. Yes, I was in the ball peen division.
Yeah, absolutely.
Well, that was good. I nailed it. That was quite the backstory. I loved it.
Well, and that's a little bit, well, I guess I don't know how unusual that is, but, you know, a lot of people think about it had to be a little bit of a culture shock because U of I healthcare, and I'm pulling this out of my butt a little bit, but if it isn't the biggest, it's got to be close to the biggest healthcare system in the state of Iowa, doesn't it?
Yeah, I would. Yeah, it would be. There's a couple big ones, Unity Point and Mercy One, but they expand. You know, in terms of a central location in particular, they're definitely the largest. Yeah.
And so to be in that wheel, one, to have the thought to get out, but then to actually get out, that had to have been a little bit of a culture shock as you talked yourself through it. You know, all the things the reasons why you were going to do it, but then to actually do it was probably a little bit of a, like, how did that feel? How did that feel going from that system to where you are now?
I was scared to death. I was terrified of that because at the time I had 21 years at a single place.
Yep.
I knew the stuff inside out. I actually really liked my job.
Yep. I
liked my boss. Doug Van Dale was my boss. Fantastic administrator and otolaryngologist. And so it was a total leap of faith. And I told my wife, I said, I might get right up to the edge and decide not to do this at the last second. And so the board here was incredible. I interviewed with them, and I thought, I may not make the same, when I come down here. But they made sure that they not only matched it, but did better than what I was making at the university. And so I was like, it's kind of
no brainer.
The signs are there. It was, was supposed to happen. And I was scared. Actually, I was in Washington D.C. when they made the offer to me, and I was giving a talk at the AAMC, which is the American Academy of, I don't even remember what it stands for now, but it was a big event.
It was a big deal.
Yeah, it was so big I can't remember the name. Well, you want me to tell you the story about that?
Yeah.
So a colleague of mine, her name is Beth Jaggers, she asked if I would. So you send an abstract in and you say, oh, this is what we want to talk about, right? Because in academic medicine at the university, you've got some requirement to either publish some papers or do poster sessions or present. So every year I would do a couple of presentations. So I told her I would help her do a talk on project management in healthcare. which is something that I've done a lot of. I mean, that is to say, hired project managers. I would be a terrible project manager. My attention to detail is terrible. So anyway, we were supposed to talk to a room of about 45 or 50 people. And so we were kind of prepared. She's like, I'll handle the presentation. I'll handle everything.
Yeah.
So we got there that night. They called and said, they've changed. They had to change your room. You had 150 people who are signed up for it now. And, I'm thinking, I've not really seen the material, all that. I'm not feeling great about it. It's kind of, go out to Washington, you check the box, you're going to do your talk. And the next morning they called and said, we had to change your room again. We got 450 people signed up for this now.
And you're not sure how
and I'm
tight
like,
you are on the material.
I'm like, I don't want to do this anymore. Yeah. So we got into the lecture hall. It was a huge lecture hall. Yep. And this guy, the sound guy, there was a sound guy. That's how big the place was. Came over and he put a lapel mic on me.
Yep.
And so I'm standing there and I'm thinking, how like you have a paper due or a test that you're totally unprepared for in school? Oh, you'd know, of course.
I know very well.
Right? And that's how you're feeling. You're like, oh my, and I'm starting to sweat. And then they bring in 4 huge cameras at the back of the room. They're streaming it and they're taping it for posterity. Yep. And there's all these people just start piling into this place. And I'm like, not only is what I'm talking about not particularly innovative, like, which is what you'd like.
Right.
I don't even really know what I'm talking about. So like I was just standing there and the walls, there was this huge rumbling that was coming. I'm like, what in the hell is going on? And everybody's looking around like this. And the sound guy comes over and he goes, sir, you're breathing into the lapel mic too hard. It was my breathing. I was so nervous. So anyway, I got through it. It wasn't very good. It was done. It was just one of those things. Anyway, I went back to my hotel room. David Bruns calls me. He's like, I'm here with the board. And this is an offer. We want you to come work down in Washington. And so
that's awesome.
I basically accepted it right on the spot. And my boss at the time was in Washington, D.C. with me. So I was like, hey, you want to grab a drink quick? And I told him, I said, I'm leaving. And called my staff from the airport the next morning and came home and made plans to start working down here.
That's awesome. One of the biggest, I guess, themes or things we wanted to hit on today that we think can just relate to a lot of our listeners is just like the crisis with rural healthcare and small town healthcare and the problem with consolidation and, going and see your local doctor. Like it's becoming, in some places across small town America, it's becoming really hard to have a local doctor.
Yeah,
you got to travel. You got to go travel. And when you got a healthcare issue, you don't really want to go travel as far as you have to. So like just talk about what you're seeing, what you think's the biggest problem and how you're trying to combat that here in our town.
Maybe your thoughts on, because obviously large hospital systems are struggling too. I mean, the whole system has problems, but like how did we get to where we are today? Because everybody knows all across the country, there's a lot of smaller hospitals that are either closing or getting bought up by somebody else. And then sometimes they get bought up and then the next thing you know, they're still closing. So like how'd we get here first?
Well, I think there's a lot of factors about how we got here. What I would say first about Washington County Hospital in particular is that I've got a mandate from our board of trustees that we're to remain an independent, autonomous hospital. And I think the reasons for that are pretty clear and compelling. So, number one, you keep the control of healthcare and the healthcare decision-making local. So I don't report to Des Moines or Iowa City or Quincy, Illinois or Omaha. I report to the board of trustees, which are elected officials in Washington County. So that's my mandate. And we've seen it. I've seen it where you're seeing it recently, in fact, where larger systems, to your point, Torque, have purchased or done something, could be asset transfer, whatever it is, with other smaller hospitals, and that small hospital probably will lose them money when they start, or was losing money before, which made them sellable. And so those larger systems usually don't care that much about that hospital. Right. They either want it to make money, or they want to take a competitor out, or they want to close it.
Right.
And so just recently, for instance, Quincy, Illinois, Blessing bought Keokuk County, or whatever, Keokuk Hospital, I'm not sure, Lee County, lost maybe $700,000 in that first year, and so Quincy closes them. So now Keokuk has no hospital. They're trying to get things righted again now, but for the larger system, they're trying to add scale, and then the problem is they don't. If that scale is causing them a loss, it's no issue for them to just close it.
Right.
The impact on the community is huge.
Right.
So that's the first thing I would say about some of that consolidation. You're seeing the same thing in Iowa City with Mercy Iowa City, which had Mercy One out of Des Moines was their managing partner for, the last 7 or 8 years. And, they're focused on Des Moines, and they're focused on some of the other smaller hospitals they have. And Mercy is kind of on the verge. They're insolvent. They're on the verge of bankruptcy right now.
Yeah.
And so that's kind of where we are living right now in Washington, which is we're going to fight like crazy to make sure that we're not put in a financial position where being acquired or purchased looks like an attractive deal.
Yeah.
In terms of how we got here, there's been all kinds of changes in reimbursement. There's been, especially this year and in the last couple of years, wage pressures, coming out of COVID have been really significant. And I don't know if you guys know anything about inflation right at the moment, but the inflation on medical supplies in particular is really, really difficult to overcome. So you're seeing, places that during COVID or maybe immediately prior to COVID were turning reasonably good margins are now either break even or losing money. And so there's a lot of those kind of things that have come together. Another complicating factor, and this is one thing that we talked to the governor about when she was here this week, is the shortage of physicians and the shortage of healthcare providers in general.
Yep.
They're typically being consolidated in larger urban areas, and it makes it difficult for rural communities to recruit those providers. Yep. And so, we're lucky in some ways that we're this close to Iowa City. It gives us a chance to recruit from there, and we have actually a lot of doctors that work down here that don't live in our community. They live in Iowa City. It's a double-edged sword because we also have to compete with them, Iowa City. But I think it's been helpful in our case. The governor's bill, in an effort to help ameliorate recruiting, is giving PAs, physician assistants, the ability to practice without the oversight of a physician, which gives us a broader labor pool to recruit from.
Yeah.
So expense-based changes in reimbursement, and that, I'll give you another example, tort issues, so malpractice, which is a real challenge for especially obstetrics. And we closed our obstetrics program soon after I got here.
Yep.
And the obstetrics group in Iowa City that's not affiliated with the university is filing for bankruptcy because they had a large tort claim. So it's those types of things that it's a confluence of factors that are creating the crisis-ish.
So what are the steps you're taking to avoid getting bought? Like, what are you trying to do to combat those issues? How are you doing that in it? Because like you said, you got to try to go recruit talent at Iowa City and be competitive, but you're a small town hospital.
You got to keep
it profitable.
You got to keep the doors open somehow.
Yeah, so I think one of the first things to do for us, it started with culture. It's a big thing. So we are very different culturally than the University of Iowa, and so we I tell our staff all the time, we want to make this a great place to work. So for one thing, we don't pay the same as the University of Iowa, probably never will, but it's much more pleasant to work just from a general environment perspective. So we start with culture. The second thing is we partner to the extent we can with our competitors. So I don't want them too close, but I don't want them too far.
Yep.
So I want to look at things that are strategically important to them and then figure out if we can provide that to them without them having to come and get it themselves, if that makes sense.
Yep.
So I'll give you an example. The University of Iowa has a lot of employees that work in that live in Washington, that work in Iowa City and live in Washington. They have to go then drive up to the University of Iowa to utilize their health care insurance because they're in network with that, right? So I was like, why don't we just do that for you down here? We'll get into your health plan as a tier 1 provider. So your employees don't have to go up there. They can just come and see us down here. And then when they need some sort of specialty service, then they can go up to the University of Iowa. It
helps both of you.
Say that again?
It helps both of you.
It helps both of us. So we try to partner with our competitors like that. So there's kind of mutually assured destruction isn't the right way to say it, but you understand.
Right.
It keeps people in check, really. They have no reason to come down here now.
Yep.
And that freezes out a competitor from our market.
Yeah.
There's a bunch of little things just strategically like that we try to do. The other thing is to get financially healthy. So when I got to Washington County Hospital, I think we had 80 days cash on hand, which is irresponsibly low for a hospital. I think we're about 185 days cash on hand now and trying to get to about 210. We've done that through expense moderation activities. We've done that through targeted growth of certain types of services. And then we've also tried to diversify our funding stream. So if the only money that you have coming in is from patient care, you're single sourced.
Yep.
So, you probably hear us talk about our foundation all the time. Well, you guys were just at coming up with investment income, which we didn't, when I got here, we didn't have any investment income to speak of. So we've diversified our cash reserves into certain investment strategies.
Yep.
We've increased our focus on philanthropy, and we've also then targeted services that generate margins so that we can drive profitability. The other thing is, though, not all your services are going to be margin generators. Right. Our community's got to have things that available to them. Mental health is a tough one.
Yep.
Doesn't make any money, but we've got to provide it for our community.
Yep.
So how do we then take a margin producing service and help offset the losses with that? So we try to be very thoughtful about how we approach the services that we provide also.
Yeah. It's a balance you got to find of helping the community and making money.
I think mental health is probably one of the biggest. We talk about it all. We talk about it surprisingly a lot because
in this day and age, for sure,
that's something in our political system that neither side really wants to touch.
Yeah.
So the mental health services in this country were hollowed out a long time ago, and we have more and more and more problems with people that probably should have somewhere to be that don't have, and nobody wants to do anything about it. And I don't know how bad it's going to get before the government at the federal level and the state level in some of these states address it. But I feel like neither. It's really odd. Usually if there's a problem, one side or the other, they that's like their baby, and they want to take it and tell you everything they're going to do about it and everything that the other side's not. But mental health, I feel like, is one of those that both sides just like, we don't really want to touch it. And it's too bad because it's a major problem.
It's a really tough issue. And I think there's ways to approach it. First of all, there's not enough money in that particular system. I mean, you guys know as well as I do that if there's money to be made in it, people will do it.
Yep.
Right? So there's And there's so many really good people working in the mental health field that are willing to do it, not for a paycheck. They're wanting to help people. But the reality of it is, if you want to have more providers in it, you want to have more resources, there's got to be more money available for it. There's also some really unique ideas, like crisis stabilization units that they have in Johnson County that I think we could use 1 or 2 in Southeast Iowa that give people a place to go just to get past their acute symptoms when they're, I don't know how else to say it, but having a freak out, right? Rather than go do something stupid, they've got this resource available to them. But one of the things we were seeing was, so if you try to work up the chain, so if you try to treat people at the level of diagnosis and get things under control at that point, or before identify it earlier, you can keep them out of the acute phases of things better.
Right.
So we were having, when I first got down here, we had people who were coming into the ER in acute mental health distress, whatever that was, and they'd end up in our ER. We'd have trouble placing them. So we thought, you know what we need to do? That's costing us a lot of money.
Yeah.
And they're sitting there. We need to back it up so that we have outpatient services that they can utilize sooner in the arc of that progression, so that we can keep them out of our ER and then out of the hospital. And that takes some pressure off the resources that exist. So I'm hoping this week we'll actually add our second outpatient mental health provider down here. And it's a huge need in our community.
Yep.
And like I said, we only have one even now who's packed.
Yeah.
But adding a second would double our capacity, and I'm hopeful.
Yep. That's good.
You mentioned culture. Is your
he could have written
I know
he
should. He could have read the outline without us even knowing.
I know, right?
But
telepathy.
It is. He's feeling it.
I'm probably one of the smartest people you'll ever have on this show.
You're like Ricky Bobby. You just wake up every morning and piss excellence. No, but I was just going to say, you mentioned culture and how that's like your biggest, trying to recruit people here, culture, getting people to enjoy what they do. And like, I've heard from many people, because I know people that work at the U and other big hospitals, that's something that they feel is missing. That is something that I think, if small hospitals can provide that, a better lifestyle or a better work-life balance, that goes a long way. So I guess just talk a little bit about your experience with culture, what you try to do to instill it, because a lot of people miss on it, but it can be really, really important in any business. But
any business, because I've been businesses that I have worked for. I've been at them long enough that I've seen the culture build, and I've seen the culture change, and I've seen the culture go in a bad direction. And you can have a lot of things. I don't care whether you're in healthcare or construction or what, raising pigs. We try to have a good culture here at This'll Do Farm.
Just yell at each other. That's our.
We work through our feelings pretty well. But no matter what you're doing, if the culture's wrong, nothing else is going to go right.
Mm-hmm. Well, I think there's a couple things. You have to have a lot of clarity around what you're trying to accomplish. So, how do you communicate what you want to do as an organization to people? And I tell our new staff all the time, there's 2 things we want to do: take really good care of our patients and take really good care of our staff. Those are the 2 things that we care about. And if we're not doing those things, they need to escalate those concerns to us, and we need to deal with them. When I started down here, I tried to convey to people, this is what we're going to be about here. And you can either be part of that, or you can, what I called it at the time was self-select out. And the first year I was down here, we had a pretty large exodus of people that had, in some cases, worked here for a long time. And that wasn't necessarily what I was expecting to have happen, but I realized it needed to happen. And the concern behind that was always that, you won't be able to recruit replacements for them. And I sort of disagreed with that because I thought, well, if it's a great place to work, why would we have trouble recruiting people? Even if it's, in a small town. And so what I tried to do is say, this is what we're going to be about. If you want to be part of it, we'd love to have you. If you don't want to be part of it, no problem. But you should go, right? Go find something else to do. And so we had a lot of that. And that changed the culture, started to change the culture. You had people who are self-selecting and saying, I want to be here. I like what you're saying. I like what you want to do. And then we started to hire for that, right? So now you're starting to hire and saying, this is what we're here to do. This is what we're trying to do. And then I think the big, and so I used Patrick Lencioni's Ideal Team Player, Hungry, Humble, and Smart, if you've read that. That's one of the things that we try to think about when we're hiring people. Is this person hungry? Is this person humble? Is this person smart? Or, and then I think they've also added peaceful and courageous recently. But does that fit with our culture? And then I think the biggest thing that I've learned in my career that kills culture is when you don't manage poor performers. So if you allow bad apples who have bad attitudes, who are going to infect a particular area, if you allow them to stay uncorrected within your organization, doesn't mean you have to fire them, but you have to tell them this isn't going to work here, right? You either need to address that and change it or find something else, or we'll help you find something else. That is what kills your top performers. If they're around people like that, are just like, what is the point of me being here and doing this? So if you don't deal with poor performers, you're sunk from a culture perspective. You have to continually address that.
I know you say you don't just fire those people if they are poor performers, maybe you put them somewhere else, but are you of the mindset, I've always heard this when it comes to culture or just hiring and firing, hire slow, fire fast. If they're not a good fit and they're not going to be a good fit, fire fast, because you're never going to, you hire somebody, you do the interview, and they could say all the right things, and they come in and then they suck, and it's so just firing fast, getting rid of that bad apple. Is that something that you kind of try to?
I think there are definitely times when you've totally missed the mark in hiring. We have a recruiter and we have a really good HR person. We've got good managers, and we look very carefully. What I would say is we look very carefully for red flags in the hiring process. And I've, over the years, learned to listen to my gut in hiring. It's very important. If something doesn't feel right, it's like when you get married, those things that are kind of annoying before you get married are now extraordinarily annoying after you've been married for a long time. Those things that you're noticing red flags on at the time of hire will probably become huge issues later. So I would rather not hire somebody than get and maybe miss on somebody that I should have hired than have to deal with them over a period of time and then ultimately fire them. Yeah. So I've got a low. It's hard to, when I hire you, it's because you've been fully vetted. But yes, I would say you got to cut it. If it's a clear miss, you got to cut it. The other thing though is just to tell people this is the expectation. Just be really direct with them and say, look, this isn't what we want here. This isn't how we want to do our business. And again, if you don't like it, it's fine, but you should look for something else. Don't stay here and pollute our environment, So, but yeah, we'll definitely fire people if it needs to happen.
Yeah. So give us a little idea when you show up on Monday morning in your position, what's priority number one on any given day? Like, where do you start?
Well, I usually Sunday night is kind of that's my main time. I work, I'm in the office every day. And part of what I try to do is structure my week so that I have time to think. Yep. So if I'm not careful, Monday through Friday, 8 a.m. to 5 p.m. can be meetings every half hour.
Yep.
Right? Which is okay and needed, But in my position, you lose sight of the vision, the strategy. And so Sunday night's the night where I kind of go in, I look at my, I look at my calendar for the week. I think about things I have to get done. And then I sit there, and as I'm just kind of absorbing things, I'm thinking about, all right, where do we really want to be going? Yep. What's happening here actually? And just because it doesn't hit like lightning usually, right? Yep. It's a constant, like, I'm still thinking about this thing. I'm still thinking about it week after week. And then if all of a sudden one day you just kind of have an answer or an approach to something that you hadn't seen before, or you had that idea, but now you've galvanized that it's the fact that it's the right way to go. So the way I structure things in my whole existence is to make sure I have time for me to think about what I'm doing.
Yeah.
Otherwise it's just assembly line, keep the trains running on time, and which is all very important, but you can get lost in that and not do the important things. So,
is that kind of the biggest? Is that the most important role as a CEO? I mean, I guess it's different in every business, but in your role as a CEO of a hospital, are you the vision guy, or is that what you really like? That's what you're good at. That's what you're going to stick to, and you'll go to the meetings, but like at your core, that's it.
Yeah, and yes is the short answer. I don't know if that's true of every CEO. We have. So one of the things I tried to do early on in my career is figure out what my strengths are. And the reason I wanted to know my strengths is because I wanted to know then what I wasn't very good at. And what I found, how that equates is the things I'm not very good at are the things I don't like doing, which are detail-oriented, scheduling, planning, those kinds of things. And so as I went through, I didn't really know what all that meant, but I kept that in mind. I'm like, I like the ideas. So on my team, when I set my core team, I need to have a balance of people that like to do those types of activities that I hate.
Yep.
So there's another Dr. Schomer. I don't know if you know Dr. Schomer. He's an idea guy, like on crack. I mean, he is... he's beyond me, and we try to get one idea that's valid out of 10 that he does. The rest of them are I'm not even ready for prime time. I can't even share them with you. But he and I, often Monday mornings or several mornings a week, we'll just sit in his office or my office and we're just, hey, what do you think? 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 And he's like, that's stupid. I say, that's stupid. And then we bring it back to our core group and they're always like, oh my gosh, that's crazy sounding. Okay, but let's actually figure out if we can do it, right? And then I've got people that compliment me in terms of their ability to, how do you take a project from beginning to end, not miss steps, and keep it on schedule, keep it on budget, which is not, maybe I used to kind of be able to do it, but not really. My wife would tell you I can't.
You better take notes, buddy, because
I know.
It
sounds about right around here.
Well, it is.
But the attention to detail isn't our strong suit. We like the big ideas.
Yeah.
No.
But
so, I have done sales, and I loved sales. And at one point, I offered to take less money if they would give me a dedicated person that when I sold the project, they just took care of everything after that. Yeah. And I could just go sell the next one.
Yeah.
Because I was really good on the front end. Yeah. I was not good. In fact, I'm pretty sure that all of the contracts and paperwork that people sign today are different than they were when I was there as a reaction to all the things that I missed when I was doing that. And from there, then I worked in managing a group of people. And that was really good for me, but my heart, the thing that I am the worst at is I start out delegating, and if it doesn't go the way that I think it should go, then I want to go fix it.
Yeah.
I want to go do it.
Yeah.
I'm the guy that with my boys, I'm the guy that stands over their shoulders and gives them about 3 seconds to go, oh, just let me do it and watch me. And that's one of the hardest, for me, managing other people was way harder than selling because just the way I'm wired. Yeah. And for anybody, that's one of the hardest things of the progression of any business. You know, as you start something, you get to a certain scale where you have to start delegating.
Yes.
And for a lot of people, the most difficult part of that is the delegation and letting those people do what they're good at, and also what you said, recognizing what you're not good at.
Yeah.
And
being okay with that.
And being okay with it.
It's interesting. I was talking to Kiowa just the other day. We were sitting around the fire pit, and he's doing this social media management business, for lack of a better word, I guess, and it's getting to scale now where he's kind of like, I need to kind of maybe outsource some of this. How do you maintain that quality control, right? And I told him, I said, the hardest thing that I have ever done in my career is going from being a strong technician, somebody who's good technically, to handing that off to somebody else to do. And what I've learned is that if you're going to do it, you have to be okay with the people doing it differently than you think they were going to do it. And what I've also learned pleasantly is sometimes they'll come up with something better than what you were thinking. Yep. And so I have just, I figure if I hire right and I got the right people, I'm going to let them run. Yep. And it's tough sometimes, but I also don't have time to really micromanage. So
yep.
It is definitely, and when you get to scale, because like you might be the best person at that thing, can you replicate yourself?
Yep.
It's really challenging.
Yeah, and nobody that you hire to do a job that you are doing or have done is going to do it in your mind
right
as good as you, but they don't have to. They don't have to, and they might do it better. You also got to be a strong enough person that you can back up and go, wow, I wasn't near as good at this as I thought I was. This person's way better.
Yeah. I think that's really insightful. And you got to kind of check your ego a little bit, I guess. And if it's better for the organization, I don't mind if they came up with the idea and I didn't,
Right. 100%.
So what can people here in Washington County do to kind of help what you guys are trying to do? What your vision is for our hospital? But I guess broader question, if there's another community out there from one of our listeners or watchers, like if they're in a small town and they feel like they don't want to get bought up, what can they do to support their local hospital from that happening? Because I think a lot of people on this show want to keep small town America going. They want to have local health care. They don't want consolidation. They don't want
fewer choices.
Yeah, they don't want fewer choices. They want their options. So what can they do?
Well, I think first of all, they can patronize the local hospital. If they need health care, rather than go to a larger system, at least give them a chance. I think our community in particular is incredibly supportive. When we have new physicians come into town, you wouldn't believe the response we get from people. They're just overjoyed. We just hired a pulmonologist the other day, and we're having a specialist social early in June where the public can come in and meet the specialists, and they're just so appreciative of the doctors.
Yep.
That doesn't happen in the more urban areas, I would tell you that. There's that relationship. People really want them here. But giving the doctors that feel, have them want to come to some of these areas. There's programs also, I would say. We can access loan repayment programs because we're rural that other places can't, and there's things that we may be able to offer. Leverage those types of programs. In our case, another thing has been establishing a foundation. So we have a foundation that's a separate tax ID, separate entity that allows us to, as I mentioned earlier, diversify our revenue portfolio. And that has allowed us to offset a lot of capital purchases in particular and, facility improvements. And that's been a huge thing for us. It's been a lifesaver, a game changer, in fact. The community in 1995 started that with like bake sales, and it is now a huge part of what we do on a daily basis.
Yeah.
Do you enjoy being here? Like, do you enjoy running the ship here more than what you experience at a bigger hospital?
I do. Yeah, I do. Primarily because of the impact I feel like I can have on my local community. So you guys live here, right? If you need medical care, I want us to be able to take care of you, right? Yeah. That and up there, my job before, you'd walk the halls, you never see anybody right? Yeah. I mean, it wasn't, you didn't feel like you were serving your community per se.
Right.
So this, and that's a personal thing, I think. That's just for me, I'd like to serve our community in different ways, and that's one of them. I think that we should have good health care, and, so that's what I'm trying to do. And for me, I can see it, and that makes a big difference.
So what's next for Washington County? Like, what's your next project or goal that as a hospital you guys are working on accomplishing?
So there's multiple facets. Kind of one of the recent ones was adding the helicopter, which was kind of a cool project. So that's here 3 days a week. I'd like to move that to a 24/7.
Are you flying that?
I've ridden in it. They actually asked me not to fly it.
Yes. I can imagine that was probably a good choice.
Yeah,
the board.
They actually asked me not to touch it. And the point of that was to not only to help our patients, if you have a heart attack or stroke and you're in our ER and you can, it's a 12-minute flight. You can be in the cath lab at the University of Iowa in 15 minutes getting a stent put in your heart, if you're having a heart attack versus, much longer if it's still fast by ambulance, but it's much longer. But not only that, but you cut 20 minutes off of your response time from flying down to Southeast Iowa, someplace else. So it's not only for us, but for this corner of the state, it's very helpful. We're trying to also add specialty care. So in the last, I'd say 18 months, let's call it 2 years, we've added general surgery, endocrinology, which is, hormone treatment, diabetes. We have the only endocrinologist between here and St. Louis. We've added rheumatology, which, arthritis, lupus. We've added dermatology. And I just mentioned last week we added pulmonology. And these are individuals working, in most cases 4.5 days a week at our institution.
Yep.
And they're pulling regionally. So continuing to add specialty services as we can. We're considering oncology, cancer care, and a larger orthopedic presence over time. And then we want to continue to bolster our primary care. So we've got multiple primary care providers that are going to be retiring. And so we need to continue kind of freshening that well of primary care providers. So, if you have colds or you need your physicals or whatever, you can be well taken care of.
What has to happen in this country for smaller systems to get obstetrics back?
Well, I can kind of give you the financial reality of what we were facing when we closed. So the last year we were open, which was 2018, we performed 130 births, whether that be just a vaginal birth or a C-section.
Yeah.
And so in order to support those 130 births, which is like one every 3 days.
Yeah.
For us, you have to have 2 OBGYN physicians that are basically surgeons, because if you have a
Yeah, if anything goes
C-section
wrong.
that has and they have to be on call 24/7. So you've got 2, and they're on call every other night. You've got anesthesia that has to be on call 24/7 in the event that you need a C-section, and you've got nursing that has to be on call 24/7 as well. So you're talking about millions of dollars in outlay for 130 births. Mm-hmm. So, there was one of 2 directions you could go, I suppose. One is that you close, which we decided to do. The other is invest a lot of money to become a regional birthing center. And at the time, there were more
options.
So more have closed since we closed. So the first thing is there's not enough OBGYNs. That's number one. So staffing is very difficult. There's much like healthcare, there's not enough money in the system to make people want to. I'm just being real. I know we want to do obstetric care, but if you're losing millions of dollars on it a year, you're threatening your ability to do primary care.
Yeah.
You're threatening your ability to provide any hospital services at all.
Take down the whole ship.
It'll take down the whole ship. One of the things they recently did is they did pass tort reform limits. So you may not know, but obstetrics has the highest risk on the tort reform. So it's the most expensive malpractice stuff that you can find. Iowa has been pretty thoughtful in fixing that. So staffing the financial model, which doesn't work, especially in rural areas, and the tort reform, which has kind of been fixed, but that's the financial reality for us.
Yeah, just not a big enough market to make it work financially.
Well, the way we analyze it. So when I got here, I'm like, maybe we can save obstetrics because they'd made the decision to close. And it was a couple months after I got here that we actually did close it. So I thought, in that meantime, I'm going to make sure that it's the right decision. I thought even if we were to get every birth in Washington County, which would have been impossible, we were looking at 300 a year.
Yeah,
we're still looking at one a day. And so it just, I think that if the financial model turns around, if we have, PAs and people like that could maybe do parts of the process differently than relying on OBGYNs, maybe there's a chance that we can revitalize these in rural areas. But you'd have to get scale. You'd have to make it a center. I would think we'd need about 600 births a year to have that start to make sense.
It's up to your generation, Sawyer. Better
have a lot of babies.
Better just get busy.
Have a lot of better get busy.
Better get going. Me and Kyle better get going.
Yeah, I sort of envy you. Sounds kind of fun.
Yep. Practice makes perfect.
Yeah, it does. Got to get your reps. Got to get your reps in. This is kind of a curveball, but I was just thinking about it, sitting here thinking,
There you go.
I don't know. I feel like this is a broad question. This is a big question, but 2018, you took the job, right? 2 years later, big healthcare crisis across the entire world. COVID. How the hell did you handle that shit show? And, there's a lot of stuff come out of that, but, a lot of people thought, it came out that a lot of hospitals out there were reporting as much COVID as they could to get funding from the government. And I think a lot of people out there lost a lot of trust with big hospitals that were doing that shit, because they were, what do you say? Doing something, they were telling the numbers, they were saying the numbers were one thing, but they weren't actually that. It wasn't really that way. Mm-hmm. So how did you handle that? And what are your overall thoughts about just COVID as a whole in the hospital?
Well, as far as your hospital, how did that affect? Because on the one hand, in that situation, everybody's thinking about healthcare, but you had the same problem that every other business had in the fact that nobody could go anywhere. So unless it was, if I'm right on this, unless it was like emergency surgery, everything else got shoved out of the way. So you weren't doing your normal amount of business. What was that?
Yeah. Well, so first of all, it was the most miserable time in my career. And to be honest with you, I'm still kind of processing parts of it because I really couldn't figure out what was, at times I couldn't figure out what was happening.
I think we all are in that boat.
We all were in that boat.
Our reaction at a national level, it was so surprising to me that I don't know if I was taking it too lightly at the beginning. I've been through SARS, West Nile, MERS, Avian Flu, H1N1 during my career.
Yep.
So when I was in the Heart Center at the University of Iowa, H1N1 flu was killing young mothers, and for whatever reason, we had a system called ECMO, extracorporeal oxygen extra ECMO. I don't know. Elizabeth is going to kill me if she watches this. Hopefully she doesn't. Anyway, it's basically a heart and lung machine, so that when your lungs are damaged and your heart isn't working, they put you on this, and it allows your lungs and things to heal while you're on this heart and lung machine. So when you have that flu, that respiratory flu, it won't kill you, and then they put you back on your lung and heart and stuff like that, and then hopefully but every day, all of our ECMOs were full during that time. And so I'm like, well, this is just what we do, right? We take care of these patients. So when COVID came along, I'm thinking, well, this is another MERS, this is another H1N1. We'll deal with it like we have before. And then, the difference was you didn't read about it in the paper every single day, and there wasn't this
mass story
panic also, so I think I went into it kind of like, we'll just handle this like we've handled other things in the past. And so, and then we started meeting to try to, figure out how do we need to protect people. And so, we have what I was thinking were standard precautions. So if you're going into a patient's room or treating a patient that's got tuberculosis, we already had mechanisms by which we would treat them. I'm like, why wouldn't we just use our standard kind of precautions? And people were worried about our hospital getting full. But the reality is, kind of in that March, April, May timeframe of 2020, 75% of our volume just went away.
Yeah.
Went away. There was nobody in our hospital.
Yeah.
Couple maybe. But the most we had COVID patients in our hospital is 9. And that was the max we could hold. And there were a couple times, November of 2020 was the worst that I recall, when the university was totally full and Mercy was totally full and we were totally full and there was no place to move people. So from that perspective, it was completely devastating for some people. But again, I go back to the H1N1 flu. It was completely devastating for some people there too.
Right.
So I was not fully understanding the reaction we were having to it. And still to this day, I'm kind of working through it. But we did some things that were really innovative during that time that are also, we shut down our clinics and we created a respiratory therapy clinic just designed to take care of infectious, respiratory issues. Everybody was gowned up like in hazmat suits, and we had to downsize our staff. Just in that short period of time, we lost, I think, $3.7 or $3.9 million.
Yeah, because basically you weren't doing anything else.
There wasn't it. So I was like, most of the people who were there weren't dealing with acute respiratory issues. So we had to start and at the time they had the enhanced unemployment.
Yep.
So I'm like, well, let's get them off our payroll rolls and get them on that. They were making more money in some ways doing that anyway. To your point, Sawyer, I could see, we certainly didn't, but there was an enhanced payment for patients that had a COVID, what's called a DRG or diagnosis related group. So if you had a patient that had COVID, you were getting some kind of supplemental payment. My experience was that wasn't happening, at least like people trying to take advantage of that in any sort of structured way. I didn't see that, definitely not here, but I didn't really see that happening, and certainly not as a way to get rich. Mm-hmm. Then all the other things that happened around it. I mean, we were working, I think our management team probably worked 70-hour weeks for 3 months or more, and we had people kind of just breaking down, but it wasn't necessarily because we were being overwhelmed with patients. We were planning and kind of trying to come up and trying to deal with
rules and
the rules and regulations that were coming in. And then there were times where we did get overwhelmed with patients, and then we were dealing with that also. But, I'm still, my management team they know they were involved. It was tough for me, really personally tough for me. For one thing, I'm a registered Republican, but I'd say I'm a libertarian.
Yeah.
And I'm big in personal accountability and personal choice. And I don't like when I'm told to do something. And so I struggled with that part of it a lot.
Yeah.
Mm-hmm.
And also, having kids in school who are getting their experiences cut short,
mm-hmm.
augmented, and I didn't think it needed to happen. Mm-hmm. That was really tough. I'm a little bit scarred from it.
Yeah, I think I think that was the reality for a lot of Americans. They just felt like, you have the experience of being in the healthcare industry through all those other diseases or viruses or pandemics, but Americans did too. And then it just was so crazy that it was handled in such a different way when it wasn't like it wasn't like the numbers were coming out that it was the Black Plague where everybody was dying. It was very similar as those other, like the other.
There were definitely
pandemics.
aspects that were so. You got to be. Everyone's different a little bit, and this was a serious thing, but the thing that kind of drives me crazy is nobody's like kind of going back and saying, "Oops,
what'd we do wrong?"
Yeah, I think at some point when we get a little further, there's going to be papers that come out of this that say, this is really how we should have done this, or this is how we should have approached this differently.
Do you feel like that's the consensus right now in healthcare just across the nation? Just most hospitals just are kind of like just processing what the hell happened and like, why did we do this?
Well, I don't know. That's what I'm doing. I think that a lot of places think that they did exactly what they needed to do to save lives. And I certainly think there's some validity to that, but I think it's also kind of overkill. I mean, there's been and it's changed the culture.
Yes.
In a lot of ways. And
yes.
I think that's an interesting aspect of this in ways that I don't really understand anymore. It seems like it's sort of led into a whole bunch of things that don't make a lot of sense to me.
I think one of the takeaways that has really stuck with me is just how individual people process that, and it's like everything in this country, and the fact that you have people with differing views on everything, but the reaction from on the one side of they wanted to go about their everyday lives like nothing happened.
Right, yeah.
And that it was, I think there's some people out there to this day that don't even believe it was real. You have that. And then the people that were like literally afraid to leave their home, or if someone in their family had it, they would quarantine that person, not even let them out of their bedroom.
Yeah.
It's a really, culturally, you're right. It has changed. It did change the culture, and that broad reaction and the conflict between people with differing viewpoints kind of crazy. Like,
Oh, it was crazy.
It was very polarizing, and really
Yeah.
the answer, of course, is probably something in the middle.
yeah,
And
correct.
it didn't seem
As it
like we could
usually
ever
is.
get there. Like
No, we didn't.
if just for instance you say, well, you don't need to wear a mask in a store, is like blasphemous on one side and blasphemous on the other. Like, you couldn't even, there was just no middle ground. And that's, I agree with you, Torque. I mean, I think and like for me, then also, I know how I personally react. If you're telling me I have to do something, I'm going to,
Yeah, my instant reaction.
I'm going to
is
move
no.
away from that. Right. And so
Yeah, it's hard.
I've always been that way. And so if you provide me with the facts and you say, these are the things we think
Yeah,
might be good to do,
yeah,
then I'm more apt to do them if you say you have to do this.
exactly.
And you just couldn't get past that kind of, there was a right way and a wrong way, or, even a right way and a wrong way the other way. So it was somewhere in the middle, as it usually is.
Yeah, and I mean, to this day, I still think there's cultural inside hospitals anyway. I mean, you still have hospitals where you are required to wear a mask.
Yeah.
No matter what. And, it's getting to a point now, you back to that happy employee thing. I think employees are sick of it. Some employees are getting really tired of still being told you have to wear a mask.
Yeah.
And this whole mask thing is still going on when we're
Well,
3
and it
years
plays-
removed.
It plays into, you have places that
They're not giving.
the mask is dependent upon whether or not you receive the vaccination.
Yeah.
So it's a whole.
You're not giving the employee their personal freedom to express themselves however they want to.
Well, there's that, but also I would say, so we stopped having people mask in March of 2022, at least maybe 2021. It might be 2 years now, really early. Because, and so what we just started to do is we were like, okay, let's track the data. Let's make sure that if we're having people do this, that it's for the right reasons, so that we know that we're actually protecting them. So our patients, are we spreading anything to our patients or vice versa? Or are we seeing a higher incidence of employees getting COVID than places where they're wearing masks? And we just didn't really see it, at least at that point.
Right.
And so, but what we were doing also is just utilizing our medical knowledge to employ standard precautions. So
Yep.
if you have a patient who's coming in and is exhibiting signs of an infectious disease, then you put a mask on
Mask them up.
and you gown up and you do all the things. And I couldn't figure out ever, why is it not just that?
If you're coming in with a broken toe, you probably don't need a mask.
Right. Now, I understand, there were some elements of COVID that said it could be spread asymptomatically.
Yep.
And I don't discount that. I don't know. But really, to me, it came down to if they look like they have COVID, you should take precaution to make sure you don't get it.
Right.
If you are symptomatic and think you have COVID and you work for me, stay home. It's not an issue.
Yeah.
But don't just be afraid for the sake of fear. Let's look at the data and see what it's actually telling us. And, I mean, that's what I struggled with, because it seemed like it wasn't always data driven. There was some fear, there was some propaganda on both sides. And,
Like many subjects we cover.
like ivermectin, that was the other thing. Like, did you guys, I just want to know, and you can answer this or not, but, they pretty much banned that and said that was the devil. But, we've seen, or we've researched, that it was like one of the most used drugs to treat illnesses in the entire world.
Very, very well. Oh, yeah. So ivermectin has been around for a long, long time, and it treats multitude of things. I thought you were going to go down.
I just wanted to know if you guys ever used it and if you ever saw good results with it, or
here's what I would say again. So we try to be a hospital that is autonomous, and we try to allow our physicians to practice under their license in the way that they deem most appropriate. I'm not a physician. I am not dictating to our physicians how they practice medicine. We had some of our physicians were completely against it, and some of our physicians used it. And I was asked the question because there, again, this is one of these things that just got such political blowback.
Yeah, it got rolling.
Yeah. I don't know if it worked or not. I think kind of not is the general impression I've gotten, although some people think it really helped them.
Yep.
So I don't really have hard data to tell you that it worked or not. But what I do know is that I want every therapeutic option available to the doctors that work for me.
Yeah.
And they work that out with their patients. And it's not me, if they're giving them heroin, I got maybe would say.
Probably need to step in.
Yeah.
So I'm a hospital administrator. I'm not a physician. And if it was effective for some people, great. If it wasn't, I guess the concern is that it may have hurt people or
side effects,
or was used instead of a more effective.
Mm-hmm.
Yeah.
But that happens across the spectrum of medicine all the time. And so.
Well, I think you can respect that. I mean, if you're giving the doctors the freedom to treat their patients the best way that they think, that's all you can ask. I mean, that's what you want.
So it was a pretty difficult time. And so we did some things after that. We've got what's called pharmacy and therapeutics where ideally we'd bring the providers together and say, okay, well, these are the drugs that we're going to carry on our formulary. These are the things that we're going to allow. But it's a medical decision. And they would come to some consensus across that as medical doctors, not as an administrator, for instance.
Yeah.
And they, that's part and parcel. They do that with drugs all the time. Are we going to carry this thing or that thing or not? And so, again, there it could just be plugged into our normal process.
Mm-hmm.
So,
yeah,
it's like most subjects that we end up dealing with on Barn Talk. What we always say is, today, whatever the problem is, common sense is in short supply in a lot of areas. And usually, just like the problem we talked about, the way you explained it seemed like you guys are using common sense, and that works pretty well. But there's a lot of places in our society where it just seems like there isn't anybody in that room that says, wait a minute,
there's got to be a middle here.
Let's think this through.
Yeah. Mm-hmm.
And that's where we get off, and I don't care what it is.
The extremes of both sides.
Yeah, we get off on these tangents, and you just shake your head, and you're like, what are people thinking? Well, a lot of times, the fear or the
emotion.
Yeah, get involved to a point, and then common sense kind of goes out the window.
I think, and I mentioned it a couple times already, I'm a data geek. So I work with a guy in Austin, Texas. I've worked with him for years. He does all my data development. When I have a problem, when I have a vexing problem, the first thing I do is he and I get together and I say, I want to look at this from a bunch of different angles because I don't know the answer to this problem. Right. And as I do that, if my goal is to take out the unknown, my goal is to replace that with a common sense approach, with a valid argument for whatever decision I'm trying to make. But as you do that, you remove the emotion from the process.
Yep.
You remove the fear from the process because you're seeing, okay, this is, is this competitor beating me in this geography?
Yep.
Well, I don't know. I'm worried that they are. I'm mad at them for trying, whatever. I start looking at the data. They're not there. Or, yeah, maybe they are, but it's not hurting us.
Yep.
Okay? Present that. Now I don't have to worry about, so I don't have that emotional reaction to it. And I do that as I prepare for contract negotiations, big decisions that I have to make. And I find that data level sets everything and brings people to a middle ground, right?
Yep.
Say, okay, let's work from the facts
Yep.
rather than how we feel about this and the conjecture and the fear or the gut feelings.
Yep.
And that I found to be very effective through the course of my career.
Yeah.
That's awesome. No, that's really good. I just wanted to get your thoughts on it because, it's our first healthcare person that's been
Yeah.
on the pod, so I just wanted to talk to you because it, affected a lot of people. So
COVID sucked, and in some areas where people really got hurt. And I'm not even talking just patients. I'm talking about healthcare providers that got burned out, that got worked really hard, that were overworked, that ended up in some cases leaving the profession.
Yeah.
It was a big hit from that perspective too. So
Yeah, I think we've. I mean, there's a lot of areas that the labor side of it is going to be hurt for years from this, from the number of people that basically employees in health systems that just got alienated to the point that they said, you know what, I'm going to go do something else.
Yeah, a combination of that and then just the general makeup of the workforce now, where you've got, baby boomers that are retiring at like, I think 10,000 people a day turn 65. And so you're talking about mass exodus in addition to, being an unattractive field to work in during COVID. And that's, not only contributed to it making it difficult to find employees, but the wage realities are way different than they used to be.
Yeah.
So
I gotta get one more good Todd story out. And I talked to Kiowa the other day.
I feel like I've not been as funny as I normally am.
No,
This is serious.
This is for you guys listening. I've known Todd for years because my one of my best buddies is Todd's stepson. So Kiowa, shout out to you. But when I told him I was having you on, he's like, I've talked to him before, but it wasn't always sunshine and rainbows to get to the point where you are today. You've had humble beginnings, and talk about the first time you had to go buy a suit, because I think people can really, you seem like
story.
your shit, right? But it wasn't always that way. You have to figure it out as a young person, and so give him a little background on that a little bit.
So when Kiowa's mom and I first got married, slightly before that, we lived in a garage. I mean, it was a 2-car. Like, I don't want you to think like
okay, all
some
right.
sort of cheap, but
That's way better.
we
That's
didn't
a
have
level
any
up.
money. So she owns an earth moving company, and they were still kind of fledgling and going through some really difficult changes in the industry at that time. And I was just getting my administrative career going. And so we lived in a garage. Like I said, it's a 2-car. And so my boss at the time invited me to go to Chicago for a conference. And I was like, look, I have khakis and like a dress shirt. And he's like, all right, well, we're going to go buy you a suit on our way to Chicago. So we stopped at this clothing store. And I mean, I had maybe $35 in my bank account at the time. I remember that. And we stopped, and I walked in, and he's like, all right, go in, buy a suit, right? So the guy is helping me, and he starts measuring me, and I'm like, oh, no. I hope they have like $34.99 suits here. But he starts measuring me, picks out a suit, takes it upstairs right there, starts tailoring it for me. And takes a shirt, he grabs a belt off the rack, a couple ties, and just takes them up. And I'm not even asking any, I didn't even think really to ask questions about how much it's going to cost or anything like that. He rings it up. It was almost $800. And so I just about shit a pancake. I didn't know what, so I wrote him a check.
Yep.
And I called my wife or wife-to-be, and I'm like, hey, I'm on my way to Chicago. I just bought an $800 suit. She's like, you don't have any money. We don't have any money. So I don't remember what happened. We had to scramble to figure out how to cover that check.
Oh, my God.
And I wore that suit for that. It was my only suit for 5 years, I think. I forgot about that story.
Mm-hmm. No, I just thought that was a good one. And
shout out to Shane Cerrone for helping me buy that suit.
Yeah.
I had, at the time, so you had to take the GMAT to get into the master's program at the university.
Yep.
It was $200. I had to borrow money from a guy to take the GMAT to get into my master's program. And I did. I paid him back over 3 months. Paid him 60 some dollars a month for 3 months. Paid him back, and now I teach in the program.
There you go.
That's pretty awesome.
I teach usually one semester a year, and teach the capstone program called Business Integration. I like doing that a lot. So
You just kept going though, kept fighting.
Well, so when I was growing up, my dad was a guidance counselor, and my mom didn't work, so we didn't have a ton of money, and they were okay with that. We were fine, but we were sort of middle class or lower middle class. And when I got to college, they couldn't help me very much, and so there were times in college where I was hungry, like physically hungry.
Yep.
I remember they didn't serve food in the residence halls Sunday night. So I would go Sunday afternoon to Monday morning without eating anything. Like I didn't have any snacks or anything. And I remember thinking, I am never going to do this again. Yep. And so that instilled in me ambition. Like at the time, you couldn't believe. I was like, I'm never going to be in a situation where I can't eat, or my kids can't eat. And that, in addition to just being, naturally ambitious, those two things kind of came together and just made me want to just conquer the world. I worked like a dog then after that.
That's awesome.
Do you feel like, this is off the subject, I just thought about this, but that story, in the farming business, this is a common conversation that I have with guys. Now our kids are older, but I used to have this a lot when our kids were younger, that we all want better for our kids than what we had. And we have this innate need that we don't want them to have to struggle. But so many great businesses that have been started, and so many really good business, not only business people, but just productive members of society, that level of achievement has come from the struggle. Mm-hmm. And we used to talk about this, and I mean, because you really didn't know what you were getting yourself into, because when you were in high school, you didn't help, neither you or your brother helped that much on the farm because you were in so much stuff. When I was a kid, like you worked first, and then if you had time, you could con your brother or your mother to haul your ass to town for whatever. But the other thing was, we didn't really know that it was struggle, because that was just what you did. It's like when my dad talks about, like, not to beat the dead horse, because I feel like I said it. It's like when people asked my dad, he grew up during the Depression. They would ask him what that was like, and his answer was always so disappointing to people that wanted a good Depression story. He'd say, well, we didn't have any money, but hell, nobody had any money, and we just ate from the garden, and we had a cow and this, and you just didn't buy anything because you didn't have any money. And people are kind of like, that's the best you got, But it was just, that struggle was kind of universal.
But it's interesting that they actually had it bad, whereas people today, by comparison, don't really have it bad,
but
and
perceive
think they have it bad.
Exactly. So that's my I guess my statement or my question to you is, it's like, as a society, I feel like it's harder and harder, because we have people coming up that they want a job, and they want paid very well, and they don't want to get their hands dirty. Like, they
don't want to struggle.
And they want to move into that leadership role in a year or something.
You were there 20 years.
And it's just so, like, if you don't have that frame of reference, of what it is to go without, what it is to struggle, what it is for things to be hard, on the one hand, it's really hard for you to have, to know what's struggle and what isn't. But then the other side of it is, and I think that's a problem we have today, is people don't appreciate what they have because they don't know how easily that can all go away. I don't think we're probably going to fix it here, but I feel better getting that off my chest.
Well, I think I think the best gift that you can probably give a kid is
A beating? A beating?
A beating?
Oh, no, we better edit that out. I can't say that.
is the gift of understanding the value of hard work. So I think that if you work really hard and you see the fruits of that yourself,
Yeah.
and you see that direct benefit from working really hard in whatever pursuit that is, that's the biggest gift that you can give somebody. And I don't think there's anything wrong with taking care of your kids, because like you said at the beginning of that, you want them to have a better life than where you might have started from. But you have to also give them some perspective on, this isn't what everybody has.
Right.
And people have sacrificed along the way. My dad was in the Vietnam generation, right? And he gave 2 years of his life to his country. I never did that.
Yeah.
My grandfather before him fought in World War II.
Yeah.
That was a miserable time.
Yeah.
And to be honest with you, I think part of it, Torque, is they didn't have time to think about things being bad.
Right.
Like, there's so much given to our generations and culture now that they don't have to work. They don't have to grow their own food. They don't have to do the thing to keep them alive. So now they have time to think about how miserable they are on some level. I don't know how else to put it.
Yeah.
That's a good point. No, that's good. That's
People
true.
today have time to worry about how the pig felt before he became bacon, instead of just being thankful that they have bacon.
Yes.
How do you like that time?
There you go. Right on the money, baby.
I think that really is sort of the case. There's not almost, it sounds weird, there's almost not enough struggle.
Yeah.
Right? Or the struggle that there is almost is manufactured or
frivolous.
Fabricated, or I'm sure it's important to some people, but really at the baseline, if you look at Maslow's hierarchy, it's we have food and shelter and whatever the other one is, and I have it.
Yeah.
But I don't have to worry. I haven't worried about it. So, is the next thing like worry about everything else and feel guilty about everything else and be afraid of everything else? I guess so.
Well, speaking of all this work, all work and no play makes a very dull boy.
Yeah.
And you have actual talent. Not only are you a smart individual, you have actual talent. So what do you do when you're not administrating?
Well, I like to tell people that I try not to be your average normal CEO, kind of the stuffy, suit wearing, boring. I'm generalizing, of course. There's a lot of very interesting CEOs, but I gotta have other outlets. Some guys like golf, and I don't really like golf that much, and people boat. I like to boat a little bit, but what I really like to do is play drums. And so I am in a couple bands. And so we travel locally, but play a lot of gigs. And I find that it's just such a huge gear shift change in my day that it keeps me really centered. So not only that, I like to do theater. So I just want to preface, I was a really good athlete. I'm not just doing like music and theater now, okay?
You're the Renaissance man.
I guess so.
Well-rounded.
I got into theater about 2018 on a dare from my wife. She told me to go audition, and I was scared.
Yeah. What was the first play that you were in? Was that here?
Yeah. Arsenic and Old Lace.
Yeah.
I played Teddy Roosevelt.
Yeah.
But yeah, we had a couple of margaritas, and I felt like I could audition then.
You felt moved.
I was moved to audition.
Yep.
So yeah, I love doing those types of things, and it keeps us really busy. But if I'm not super busy all the time, idle hands are the devil's work, or however that.
Yeah,
probably.
something like that.
Playthings. Is that
Playthings.
what it is?
Devil's playthings. That's
Devil's
exactly
play. Yeah,
right.
I think so. That's
Yeah, and I'll give you credit because I've known you for a while, and you do a very good job of keeping work at work. At least when I came over,
Yeah.
it was you do a good job of always being the family man and having fun and never bringing that home.
Yeah.
anytime I was over, it was always fun Todd. Playing drums, playing cards, always. And so I credit you for that because it's hard to leave it at work probably all the time.
Yeah. Well, I mean, I don't know. What was I going to ask you for advice?
Yeah, right. I know, but I'm just
maybe you're getting to the point where maybe I could now. So
I won't go that far.
When you guys
I gotta ask
when you guys
you.
were little noopers, there was not really much I was gonna.
Full disclosure: all advice given on Barn Talk is worth exactly what you all have paid for it. Just know.
Yep, that's right. So you're a big music guy, though. You love music. What's your favorite band all time? I guess if you can't name one, top 3.
Oh, I'd have to say Led Zeppelin is probably one of my favorite bands of all time. Rush, so also those are kind of the really great drummers, rock drummers of all time. Neil Peart in Rush and John Bonham. And then I'd have to say the Police. Again, Stuart Copeland, the drummer for the Police, are some of my favorites. And now I listen to lots of different stuff. Actually, Primus, you probably have never heard of them, but they were a band I followed growing up. Grateful Dead, a big Deadhead. Now I listen to a lot of country music because I'm trying to learn the drum lines for, old country, some modern country, some basic.
Best drum solo. Like what if you're got the radio going, it comes on, what's
you're about to go into a meeting and you need to fuck shit up. What are you turning on?
Neil Peart's drum solo. He's got a drum solo that was on R40 that was unbelievable, that he built up over an entire career. So if you listen to his drum solos from the 70s and the 80s, the core of it is still there, and he kept building around it and building around it and building around it until he had a fully realized drum solo.
Yep.
But any Buddy Rich stuff too.
Yep.
So there's so much good stuff. It's unbelievable. Phil Collins. I don't know. It goes on and on.
Drummer is the kingpin, really, of any band.
I think he's the most important member of the band, especially if you handle all the business affairs.
That's how I felt when I played Rock Band with Clay. I did play the drums on Rock Band, and I did feel the most important. So
I was the bass player until you guys finally said, "Dad,
get out. You're not hitting the notes. We're failing.
Can't do it.
Get out."
I would say, there's the flashy folks, the divas in the band. So we got the diva singers in our band. Who are very, very talented. Yep. They're out front. They get all the credit. And you got the drummer and the bass player. We're in the back, and we're holding it down, right? To allow them to do all their fun stuff, right? Yeah. So that's
you're the anchor.
Especially when you're playing live and you're kind of live without a net, you got to have somebody who's just going to be there, be predictable, not leave it. Like, I'm not going off and doing a 30-second drum solo in the middle of a song,
Yeah. Well, you pace everything.
You do.
At the end of the day, I didn't realize that, but the drummer is the one that sets the speed of that song, and if you're going to have any consistency, you got to have that, or else.
Yeah. So a lot of that's practice, and then actually when you're playing live, like let's say John Woodward is singing a song. John knows this if he watches this. He's pretty particular about the tempos that he sings at. And so I'll listen to him, is he singing the song too fast or too slow? And then I'll make micro adjustments in the speed of the song as we're going, which you if you were sitting there listening, you couldn't tell.
Right.
But you got to always be on that.
I'm having fun, and I'm kind of interacting with the crowd and partying with the crowd, definitely enjoying watching the crowd have fun, but I'm very much concentrating on what is actually happening. Yeah.
That's cool. Yeah, I never knew that. That's awesome. Go ahead.
John's going to be upset that he isn't here.
I know. John, you're going to have to tell John you made it on Barn Talk before him. So
he tried to sell me on the idea that I should call him and he would set it up because he would want to be here. And I told him that I would do that. But in the back of my mind, I knew that while we were going to be doing this, he would be over trying to sneak bottles out of my whiskey tank, and I couldn't run that risk.
Nope.
So we just cut him out.
Couldn't run
Just cut him out.
Last question, then we'll wrap it up. But where can people learn more about what's going on at Washington County hospitals and what they can do to help, if they can?
I think one of the things is follow both of our Washington County Hospital and clinics, and WCHF on Facebook. We also are on Instagram. We have a website that's actually kind of in construction. Reach out to John, actually. This would be jwoodward@wchc.org. Keith at wchc.org in our marketing department. We need volunteers all the time. We're looking for event sponsors, etc. General support. So I'd say those are kind of the main sources that I would go to.
Last thing, and then we'll wrap it up. Where can people find you if they want you to just absolutely slash the drums at any event that they need you at?
Aces and Eights, Facebook, or I also play in a band called the Fatback Boys. That's Fatback with a P. You guys probably like that, huh?
Oh, yeah.
Yeah. You guys actually would like that band.
All right. Well,
we got to check it out.
We'll have to take out.
We need to just get you up there. Right up there.
Yep. Under
Just put you up there.
construction.
Under construction right
Is
now.
there going to be a stage up there?
Well,
it could
shit,
be
it could be. Could be someday. Someday.
Yep.
We're working to get it.
I wanted to tell you one thing. I should have brought you some shirts. I should have brought you some Fatback shirts. I didn't think about it. I'll get you some. How about that? I also have Toddcast shirts. So that's my one of the things I was going to tell you is internal communication for culture is very important. So one of the things we've developed is a Toddcast, where every week or so I do, for me, it's about 5 or 6 minutes net content that we interview somebody, that we're doing something interesting. It's just an internal communication device. But I see this platform as being so valuable.
Yep.
On being able to convey information. I really like this long form kind of thing where you can just have a conversation with somebody and not trying to soundbite stuff. Mm-hmm. So...
Yep.
Well, yeah, we really appreciate you coming. I mean, I think you dropped a lot of value, and I love what you're doing for our community, and I hope that you could help some other communities out there that are trying to, help their local community, but help their local hospital too. So really appreciate it.
You want to hear the joke I told the governor's staff?
Yep. We'll end it with a bang.
All right. So I was at the liquor store the other day, and I went up to pay. The cashier said, can I see your ID? Just make sure you're legal. I said, sure. So I pulled my wallet out of my pocket, and as I was doing that, my Blockbuster video card fell out of my wallet and onto the conveyor belt at the store. And she looked at me and she goes, "You're fine."
Yes.
There you go.
I can identify with that. Absolutely.
That probably's happened to you too. Huh? That might have happened to you one time or two.
I think mine probably went away a long time ago.
Yeah.
But yes, it would have.
I'll have my moment someday, I'm sure.
The one I didn't have the guts to say to him, if con is the opposite of pro, is Congress the opposite of progress?
Oh yeah, that would have been good. She would have agreed with you on that.
Probably. Yeah. So I actually had a couple jokes loaded up that I was going to get up and give during her visit, and I got up to the podium and I turned around and there were cameras all across the back, and I was having flashbacks actually to that
of your deal back
double
there.
AMC presentation, and I was like, I'm not doing these jokes. No way.
Well, I'm hoping that the walls weren't coming in on you while you were up here. I'm hoping you had a good time up here. But yeah, we really appreciate you coming on,
Yeah,
Todd.
I had a blast. Thanks, guys. I appreciate you inviting me.
Of course. Thanks. If you guys got any value from the show, you guys know, pay the fee, share it out, leave a review, and we'll see you back here next week for another episode.